All right. Well, listen, let's get started. We have a lot of people here, and I think that we have a critical mass of folks. There's a lot of great thinkers on this call today who are gonna, I'm sure, give us some great information about what we're trying to accomplish today. So welcome all. My name is Michael Redliner. I'm an emergency and EMS physician. I am currently serving as the president of the National EMS Quality Alliance, one of the partners who have been working and thinking about this project, this EMS Quality Improvement Partnership Project to reduce lights and sirens. This is a brainchild of this group, and honestly, building on a lot of the work that's been done over the last 50 years around this topic, which is a huge patient safety and provider safety issue. So I'm joined by some of the most remarkable folks in EMS, those who are visionary, who I know when you propose a crazy idea to do a national quality project are really on board to support this work. You know, I think all of us are kind of tied together by this idea of improving patient safety, improving the quality of care for our patients. And you're probably here because you share in that view of the world, right? We're here to take care of our patients and improve our systems so that we can you know, fulfill our duties as providers to patients. I'm really excited to kind of go through with you on this very specific adventure that's based on a lot of historical work to show how important this is for our patients. So welcome everyone. I'm not going to do introductions of our whole panel at the front, but I'm gonna introduce folks as we go through, and so. I'm just excited to work with this group. I just want to make one special mention before I start, which is I want to acknowledge Siren Murphy, who is the Executive Director of the National EMS Quality Alliance, who has taken a wild, disparate group of people and really organized our ability to get this project together. So Siren, thank you for all the work you're doing behind the scenes. And so here we go. So if you could advance to the next slide, I just want to talk a little bit about what we're going to do today. Honestly, probably this group knows more about this problem than anyone else in the world. And we're going to spend just a bit of time with some of the world's experts in this field talking about the why and reminding ourselves about why we're doing this. The purpose is not to, you know, I think if you're here, you're probably already engaged in this discussion. I know even over the last few months, there's been more and more discussion about lights and sirens and the problems and challenges we face. So it's really just to focus our efforts and think about why this is such an issue and really kind of arm this group with the data to support the work that we are doing. And so, what we're going to do after we go through the problem with Jeff Clausen and Doug Kupis are going to take us through kind of the history and the evidence about why this is important. Then we're going to turn it over to Mike Tegman to take us through the specifics about what we're going to try to do, what the Institute for Healthcare Improvement Breakthrough Collaborative offers a challenge like this, and how we're going to put it into work to really make a national improvement effort. And then Joey Grover and I will take you through what are the next steps. What does it really mean to be here and a part of this? So we're going to get started with all of the content. But before I do, I want to introduce a few people who have been incredible supporters and partners in this project. Firstly, it goes without saying that John Kramer, who is the director of the NHTSA Office of Emergency Medical Services, he has been truly a leader in the efforts to improve safety and quality throughout his career. He works to increase collaboration among all the partners in EMS, particularly between the federal government and all of the agencies within the federal government to support the work that we do nationally. And I can't say enough. I mean, we're sorry to see that he is going to be stepping out as the director, and we're really sorry to see you go, John. But we really appreciate your lifetime of service to EMS. So if you want to take a moment and really, we really appreciate you being here.
Well, thank you, Michael. Thank you for the comments and the opportunity. I will be very brief. I appreciate everybody who is joining us today. Obviously, this is an important issue for all of us in EMS. It has been a particular focus of the NHTSA Office of EMS for many, many years. We sponsored the white paper that Dr. Kupas will be talking about in just a couple of minutes. There has been a lot of discussion on emergency response and lights and siren use with the National EMS Advisory Council, even to some additional suggestions for activities that are being proposed to the council that's coming up soon. NHTSA has done a couple of crash studies. One was reported in 2011 that reflected some of the information on lights and siren use. We have just completed another study, which we're hoping will come out and be available to you all, hopefully within the next couple of months. You know, as fate would have it, the Image Trend Collaborate put out some quick facts even earlier this week that have looked at lights and siren activities over the last 5 months. And, you know, suggested to us in their database that there's been a little bit of a change, but not a great change over the last 5 years in lights and siren use during response mode. There's been a little bit of a decrease in use of lights and siren during transport mode over the last 5 years. So we still have a ways to go. It's an issue that is continues to be very timely for all of us. We're very pleased that NEMSCOA is looking at performance measures associated with that. So with that, thank you for putting on this webinar. Thank you for you all for joining us, and let's get to it.
Thanks so much, John. Before I introduce the next person that I'd like to give the floor, I just want to bring your attention. So, right, the purpose of this group is really to be engaged in this discussion and to advise on this project that we're going to embark upon. So, what we'd like to do, we're going to be saving the chat, and so as you come up with ideas and thoughts about how to move this forward, I really want you to put all of that into the chat. If something comes to mind, it doesn't matter what it is, what aspect of the project that you're thinking about, we want you to put those comments so that we have some, again, initial input from this, what we're really thinking about as a primary advisory group for this project. We really want and need your expertise. Oh, so does my dog. So, I don't know how this is going to work, but I might have to turn it over to Brian so that we can, so I can turn on my mute. So Brian Lacroix is recently named the EMS, the recently retired chief of Alana Health in Minnesota. And the reason why it's important that he's here, obviously he's a great person and we just love to have him, but he serves as the coordinator for EMS for the Center for Patient Safety, another key partner in this work. And you know, it's great to have his voice and expertise in designing and developing this project. So, Brian, I'd love to turn it over to you.
Oh, thanks very much, Dr. Leonard. So, I want to just acknowledge some of the barriers to what we're going to talk about. You'll hear from the luminaries about the problem and the case for change, but we also are pragmatic about this approach. We know that this is not easy. You know, ourselves has spent years promoting fact that ambulances, red lights, and siren is the thing to do, right? So just a couple of hours ago, literally, I entered the words blurred ambulance emergency lights and siren in Google Images. And I literally got tens of thousands of pictures of ambulances screaming around the corner with lights, you know, photographically streaking, real poignant, moving images. Well, you know, guess what? This is the image that we have burnt into the public thinking around ambulances. We've done that. I've done that. So this is not going to be easy. One of the barriers to change is tackling that issue of public expectation. That's not the only thing, though. We get that. Some of us are under contractual obligations when it comes to response times. So we have political issues. We've got operational and dispatch, you know, comm center gaps in protocol thinking and leadership. So, you know, the whole idea here is taking a wicked problem here and trying to provide you with some tools to make a difference, that we can really have an impact on the needless injury and death that we have actually imposed upon our patients and upon our providers. So this breakthrough framework model from the Institute of Healthcare Improvement is the methodology that we'll learn more about, that we hope that many of you will embrace and make a difference going forward. This is really exciting, and we really want to just say thanks for being part of this conversation. Dr. Redletter.
Thanks so much, Ryan. I really appreciate your participation. So I'm happy now that the introductions are over. I'm going to turn it over to some great people and leading thinkers in this area. Dr. Jeff Clausen, who is a pioneer of pre-hospital care. He's the father of emergency medical dispatch. He's the co-founder of the International Academies of Emergency Dispatch, and he is a longtime lights and sirens foe. So it's important to hear his voice in what we're going to be talking about today. Dr. Clausen.
Well, thank you very much, Michael. Yeah, this issue is very close to my heart, and it fits right into some of the core purposes of dispatch, evaluation, and triage. Next slide, please. And I think that may be the video. Let's give you a view of what we're up against and what happens when we misuse this stuff.
That was uncalled for. That didn't need to happen.
In Dugway, Utah, Amanda Nelson fell from her bicycle in 1988. She had only minor injuries. Despite that, an Army ambulance driver decided to run hot to a Salt Lake City hospital. At more than 80 miles per hour along a stretch of rural Utah road, he lost control. The ambulance rolled and burst into flames. Amanda's grandmother, who was riding along, died in the crash.
She's my best friend. It really hurts. It really does.
Near Chesterfield, Virginia, a volunteer ambulance driver responding at high speed to an earache ran red lights and siren right into a van loaded with small children, instantly transforming a minor medical problem into a gruesome and fatal disaster.
There was kids all over in there. There was one girl in the back seat. Her mouth was bleeding. I pulled her out and handed her to somebody.
I am very bitter and very angry that they could do this to her.
7 years ago, Sharon Freeberg was a high school cheerleader and honor student with an apparently bright future. Then, a speeding Bloomington, Illinois ambulance slammed into the pickup she was a passenger in, and everything changed. Severely head injured, Sharon was in a coma for 5 months. She will be disabled for the rest of her life. And the medical emergency that ambulance was responding to, nothing more than a sprained ankle.
As to what's an emergency and what's not. Right now, an emergency is anything that they haul.
Well, a moment of silence for that. Holy cow. First, do no harm. We can go to the next, please. I think most of us in an EMS management or medical director role have had this experience. Now comes the plaintiff, because that's what this gentleman has in front of him. And these particular issues are part of the problem, and sometimes the problem that we don't see, because not only is there extensive injury, life and death issues, there are also tremendous costs that come with this. Next. Jim Page, many years ago in the 80s, said, "We're fascinated in a morbid sort of way with the whole issue of medical malpractice." Next. For some reason, he said, "We don't want to talk about emergency vehicle accidents." He also then went on to say that the amount of money we pay for malpractice in EMS pales in terms of what we pay out for these accidents. That particular girl you saw in Bloomington, Indiana, cost the city there $10 million. They were self-insured but didn't have very good insurance. That was 1/10 of their annual budget. Next, please. Those were just some of the suits there. I used to tell people if I had to put up all the suits that I was aware of and collected over the years, we'd be showing slides until you guys went to bed at night. These are just those that you saw. Next. Interesting thing, this particular study showed that 75 cases of these sort of accidents were analyzed by the NFPA. And in those 75 cases, 125 persons were injured and 100 killed. Then made the conclusion that we also make regarding this today. Excessive speed is a principal cause. They should run slowly on the way, then never get there at all. The interesting thing is, while we've talked about this being a long-term problem, this was actually from volunteer firemen in March 1935. It justified my time as medical director at Salt Lake City, having to sit around before meetings and read these fire magazines. Next, please. It went on to say, in terms of conclusions, that many of the fatalities occurred in connection with running to false alarms and other fires, which are relatively trivial in character. This shows the value of campaigns to reduce the number of these unnecessary calls, a la us today. Next. I like to cause a little controversy in my life, and don't want to stop now. There's not a single published study or article in the history of the public safety or emergency medical literature that proves that lights and sirens save lives. There isn't one, not directly. Next statement. There's also not a single published study or article in the history, the medical literature, that proves that lights and sirens even save significant time. Now that's open to discussion. And certainly the more information we get, the more studies that are published, we're starting to see what those times are. And in the vast majority of cases, they're basically irrelevant to what was going on in the care of that patient. Next, please. According to that EMS expert, Billy Joel, you're still a victim of the accidents you lead, from his well-titled song, Don't Ask Me Why. We know that we cause, in terms of wake effect, about 5 times more accidents than we actually have reported that impact the vehicle itself. So we're sitting in this position of leadership in an area that has not really applied itself in every aspect of what we need to do to bring this to a halt. And of course, my love with medical dispatch is one of those things. So going cold on Alpha calls, going cold on Bravo calls, going cold on a bunch of Charlie calls, with leaving the truly life-threatening emergencies, Delta and Echo, to use these things. But that's when they're actually needed and where we know they have some impact on patient care. I've been growing my hair in opposition to this for, you can see now, for many years. This is my COVID lock. So anyway, I'm going to turn the time back over. I think I came in under. So Tegman, you owe me a beer.
All right.
Thank you, Jeff. We appreciate you being part of this this effort and project, and it's great to have your expert voice here. The next person I'd like to introduce is Dr. Doug Kupas. He is a medical director for Geisinger EMS. His academic and research interests include EMS provider and patient safety, including the use of lights and sirens. He authored the report, Lights and Sirens Use by Emergency Medical Services. Above all, do no harm. And he started his academic efforts back in 1994 with a paper on the same. So he's been thinking about this for a long time as well. So Dr. Kupas, welcome.
Thank you, Michael. And Jeff, this is my COVID hair. I started growing it during COVID. This is all the farther I've gotten.
Way behind there, way behind, Doug.
So, you know, when, as Jeff introduced this, I mean, it's interesting because I feel like have been on my career standing on the shoulders of Jeff, because he had been working on this for a long time before 1994, when it became of interest to me, at least from a academic publication side. But it goes back to my first starting EMS about 41 years ago, and seeing the issues with lights and siren response and transport. And as Dr. Kramer pointed out, this was a white paper that NHTSA asked to have done, and I would refer people to it. I just put this slide in. If people are looking for it, you can find it at ems.gov. You can find it by Googling the title. I think that it is very valid today. And unfortunately, when we saw Jeff's video, you look at that and the medical center seemed dated, the signs seemed dated, the old Ford Bronco sitting in the parking lot seemed dated, but you can find cases just like that today. And every time I do a talk on lights and siren, I tend to, before I do the talk, just do a Google search, and the vast majority of the times within 2 weeks of the talk that I'm giving, I can find a fatal or very severe accident with multiple children or others. So every week, every couple weeks in our country, we are still having inappropriate lights and siren use causing harm. Next slide. I have always taken and maybe it's because of the connection to thinking a bit like a physician, I've always taken the stance of, primum non nocere, first do no harm, and that lights and siren really should be viewed as a medical intervention. And, if we take that to the extreme, we don't start IVs on every single patient that we go to with EMS, including all of the ones that refuse treatment at the scene and that sort of thing. If we did that, we would cause harm. We would have a fair number of people with phlebitis, and we certainly wouldn't make most of those people any better by putting the IV in. Yet some systems use lights and siren on every response, every dispatch, and in some cases still every transport. And I think when you look at it as a medical intervention, there is harm when you do it to everyone. We should select the people that are going to have a chance of benefit from it. And that's a relatively small slice in what we continue to know and find out. Next slide. So that paper that Dr. Kramer alluded to was published in 2017, and it has about 200 references related to lights and siren that were put together up until that time. And since then, there have been a couple key ones. Jeff Jarvis, who's on this in the audience, did one in that interim since 2017. One of the questions that always came up was, all right, we can agree that it doesn't save very much time. We can agree that it should be maybe a medical intervention, but is there any true proof that lights and siren cause accidents, or that there are accidents that are related to the lights and siren use? And prior to this, there were people that would actually take the other argument. They'd say, yeah, there are some lights and siren accidents, but they're, that having the lights on and the siren, might actually be reducing our risk of accidents because we're more visible to when we're out there, and maybe it's actually reducing them. So Watanabe in 2018 published this, and I think, it's it's a very nice addition to the EMS literature in this, in that, what they showed was that if you're using lights and siren during the response phase in their study group, it increased your chance of a crash by about 50%. So the odds ratio was 1.53. During transport, it increased it more than double, almost triple the chance of an accident in an EMS vehicle when lights and siren were used during transport. So it was really the first thing that I saw that somewhat provided some evidence to say, yes, there is a change in the accident rate between lights and siren, and it goes up in both of these conditions. Next slide. Dr. Claassen and others referred to the time savings, and these are tables that are right out of the publication. And you can see here that this is at the time in 2017, there were 7 studies that looked at the time saved with lights and siren response. Now, these studies were all done in a little bit different way. So, they didn't all follow the same methods, but I think that's actually valuable, because what it showed was that in 7 places, from including rural areas and suburban areas and very dense urban areas, in doing it in 7 different ways, they found that really the time savings during response varied from 1.8 or 1.7 minutes to 3.6 minutes saved. Next slide. We can look at the same sorts of things related to response or transport. The first slide was response, the second slide is transport, and you can see similarly that if you look at those values during transport, the time saved is anywhere from 42 seconds in Greenville, North Carolina, Dr. Rick Hunt's famous study on that in '95, to 3.8 minutes saved. And I think, more and more we have to have providers starting to understand the parts of this that don't make sense. When they go lights and siren to the hospital and then stand in the hallway for 10 or 15 minutes waiting for a bed for their patient with no acute interventions going on, somewhere there should be some logic clicking in and saying, why did I need to save 2 minutes to get here to stand in the hallway for 10 or 15 before the patient got to the bed? Next slide. So we looked at the NEMSIS data in 2015, and the NEMSIS data in 2015 showed a few things. It showed us that the average or the percentage of lights and siren response used during response by EMS that was dispatched to a 911 emergency and led to transport to the hospital. So, this takes out really a lot of the refusals and that sort of thing, or lift assist. They were dispatched by 911 and transported to the hospital. 76.5%, about 3/4 of the responses in the country went lights and siren. At the same time, only about 1/4 of the transports used lights and siren. Now you can say, oh, that sounds pretty good. 1/4 of the transports use lights and siren. But actually, the facts, when you look at evidence, show that there should be a lot less than 3/4 of the responses needing lights and siren if you base it on whether there's a significant chance that that will improve the patient's outcome. And on the transport side, most emergencies are over when EMS gets there from the standpoint of the couple minutes mattering, and 22.7% is high. It varied 10% by whether it was urban, rural, that sort of thing. The thing that's fascinating is those numbers on transports varied by 21% across the U.S. Census divisions. So there were some U.S. Census divisions that were much, much lower, 20% lower than the highest U.S. Census divisions. So that shows that it's somewhat cultural. And, there are just areas of the country where they use these more and some that use them less. I think that the fascinating part that we also looked at with that was we looked at the difference between 2010 and 2015. And there was not much change at all. And the disappointing part is that the ACEP and NHTSA culture of safety in EMS was published right in the middle of that 2010 to 2015 time period. and there really was no discernible change in lights and siren use. So when we now look at some of the things like the image trend project that was released last week that showed, a little bit, but it was a pretty significant trend that just seemed to be following a trend in improvement, even though it was stated that just had a little bit of improvement. I think it's very telling that it is on a line toward improvement, and I think that's what's gotten people's attention. That's why we're talking about this. That's why there have been some other big webinars recently. The time is right because it has gotten people's attention, and there are places that are making some inroads. Next slide. So we looked at, this is in response. This is by agency, and the percentage of calls that agencies go on with lights and siren when they respond. And you can see that there are some agencies, a couple hundred that are down there in the less than 20 or 30%. But you can also see that the vast majority of agencies were going either over 90% lights and siren, or 1,300 of them were going to 100% of their calls lights and siren. So lots of room to improve based on the evidence. Next slide. And if we break that down a little bit more and we say, well, let's look at how many are going to routinely less than half of their calls with lights and siren, it's only 17% of the agencies in the country. Next slide. And there were a couple agencies that were pointed out, and there are many more that are in these lower categories. But in Tulsa, Oklahoma, they made some efforts to sort of change their response time parameters, and that led them to go down to about a third of their responses going hot. In my own EMS agency that for a couple decades has been paying some attention to this, we have been doing about 20% of the 911 dispatches as a lights and siren response for a couple decades now. Next slide. You can look at the other side of this too. This is the transports, and the lines are in here. You can see that 62% of agencies are transporting less than half of their patients with lights and siren. But again, there are still 569 plus 317 that are doing over 90% of their transports with lights and siren, which is just mind-boggling.
Unbelievable.
The evidence would show that folks should be down probably less than 5%, and that there are a lot of really safe agencies that are doing essentially 0% lights and siren transport. Next slide. So I'll leave you with one final thing, because I think public expectation comes up a lot. And people say, well, the public really expects us to do that. We often think we know what the public wants. And I think that's been proven wrong in medicine before. The idea that doctors give everybody that comes in with a cold an antibiotic because they think that they want an antibiotic, studies have shown that that's not the case. The patients are very happy to have a logical discussion about whether their condition needs an antibiotic or not, and they don't necessarily come in expecting that. But if we expect that the public wants it, then we're going to be more apt to do it 100% of the time. In my agency, where we do 20%, we virtually for the last 20 years have virtually had no complaints about not coming into somebody's driveway with lights and siren going. And most of the time, or often you'll hear dispatchers say the opposite. The caller requests no lights and siren when they get there. And E. Marie Wilson did a study in 1980 where she showed the top 5 reasons that people did not call EMS. And her number one reason where somebody with a potential serious EMS or medical issue that might have done better with EMS's care, the number one reason they did not call EMS, lights and siren. And number 2 was getting a lot of attention. So I think I love this quote from her in there where, competence is more often shown by quiet deliberateness than noisy bravado. And I think if we want our EMS crews to be looked at as quality, competent quality group that comes and takes care of people with their medical conditions, the public really likes quiet deliberateness much more than noisy bravado. So I'll leave that there. Thank you very much, Michael.
Wow.
Thanks so much, Doug. And I think just hearing from both of you, on the reasons and the decades of work that we're building this project on. It's just again remarkable to look at how in some detail this issue is really across the country. So what I wanted to take you through today, I'm just going to spend a few minutes, and then I'm going to hand it over to Mike Tegman. But I'm going to take you a little bit through the concept of how do we translate all of this information to a real improvement project. And so I'm going to go just a little bit about the background of thinking about this. And again, I think that the EMS Agenda 2050 really talks about this issue of increasing the safety and effectiveness of our systems of care, specifically related to EMS. And in this light, we need to do something about this issue to improve the safety and care and the effectiveness of the care that we provide for our patients. And I, love the model of lights and sirens as a medical intervention, because I think it's right. You got to take the risks and the benefits. And when the risks are high and the benefits are low, it's something you might not choose. But how do we take this and translate it into action? And I think that the graphs that Doug showed were really eye-opening in terms of the details of what agencies are doing what across the country. So at NEMSQA, we've spent a lot of time thinking about how to develop and think through quality measures that can be applied to any EMS agency and any locale around the world, really, but mostly in the United States and Canada. But Safety 01 and Safety 02 are very specifically built quality measures that we feel are usable and can be applied to any system that exists in EMS. We're lucky to have the National EMS NEMSIS, and we're lucky to have increasing availability of data to drive our practice. So this is the right time to have a program that's built on real data and in real-time data. So the vision for this project is really to convene a group, a sustainable national collaborative, really of associations, organizations, and individuals, and then measurably decrease the use of lights and sirens in EMS response and transport. And again, this builds on the vision of 2050 and really improving not only this specific topic, but building this culture of an attention to safety and an attention to quality that is really changing the way that we think about providing care in the EMS context. And so not only do we hope to change lights and sirens, but we really hope that this is a model of the way that we approach big time problems in the public health aspects of EMS and how we can really improve overall care for the patients that we serve and the communities and the public that we serve. So we want to save lives, and we think that this is a great way to do it. I'm going to turn it over to Mike Tegman to talk a little bit about the details of how we're going to accomplish this. Many of you know Mike Tegman. He is an improvement guide for First Watch. He teaches improvement science as an assistant professor in the graduate programs at UCSF and UMBC. He's going to serve as the improvement advisor and the facilitator for this Breakthrough Series project. So Mike, without further ado, I'd love to turn it over to you to educate us a little on the details of how we're going to do this.
Thank you, Michael. And as I was listening to to you and Jeff and Doug and Brian and John talk about this, and I was thinking about I'm going to be doing an innovations workshop at the Pinnacle conference coming up, and if red light and sirens didn't exist right now and I had invented it and was going to try to get it through the FDA's 510K approval process, I think I would have problems setting aside their recent approval of the Aldheim for Alzheimer's, which kind of changes their perceptions of what's hard to get through. But sure, if you'd go to the next slide, I'd appreciate it. So the framework that we're going to use to do this project is called the Breakthrough Series Collaborative, and this comes from the Institute for Healthcare Improvement. Institute for Healthcare Improvement's been around for about 34 years now. tackling big improvement projects worldwide in healthcare. And about 25 years ago, they wanted to try to bring improvement areas really to scale and to do large scale improvement projects. So they began crafting this breakthrough series collaborative model. And their first project was on reducing the number of unnecessary cesarean sections that were performed across the United States. And they have since tackled pediatric asthma and at this point in time, over 100 kind of large scale change projects. And so I'll walk you through how the model works. If you go to the next one, please. So we start with picking a topic, and this is a topic where we're not developing how do you make improvements, but we've already got kind of evidence about how do you make improvements. People have already done the work, and it's about bringing it to scale and spreading it on a broad range across our country, and maybe someday influencing other countries. Next slide, please. So as part of putting this together, we recruit a faculty of experts. And these are folks like the folks you've already heard present here this morning. We've got several other folks on this call. Dr. Brian Wilson, Dr. Goodlow and his team from EMSA, folks who have actually done the work. The folks in Niagara are another group. So people who've used some rigorous improvement science in order to make dramatic reductions in their use of red lights and siren for transport and response. And then we bring that group together. Next slide, please. And we work with them to really create a package of change concepts that individual EMS systems and organizations can use at the local level to dramatically and safely reduce their own use of lights and siren. Next slide, please. And then the next step, and this is something that, and Joey will talk to this in a bit, but we're going to want to get a variety of EMS systems, urban, rural, suburban, different sizes all across the country to enroll with us and participate in trying these change packages. And we'll bring them all together. And next slide. For our first learning system, and during this system, we will teach them the basics of improvement science using the model for improvement developed by the Associates in Performance Improvement in Austin, Texas, how to do plan, do, study, act cycles, and teach them the details of the change package that has been developed by the experts. And then we'll basically send them off with marching orders to the next slide, please, where they will spend 6 months or so testing all the different changes. So it's changes in your dispatch protocols, changes in your whether it's public perception, changes in your medical transport protocols if you've got those, whatever that set of changes, and you'll test them. And we're going to have a shared online data platform where everybody will be sharing their learning, their performance data, and their experiences, and kind of an all teach, all learn kind of framework. Next slide, please. And then after 6 months or so, we'll bring everybody together for a second learning session. During this time, we'll really unpack what are the lessons learned, any updates or changes we need to make to our change package based on everybody's real world experience, and then send folks out to do another round of testing and implementation of the ideas that they've learned about and developed. And next slide. And doing the round of testing and continued shared learning. Next slide. And then we bring everybody together for one kind of final gathering where we finalize the change package and then really go from testing to large scale implementation, hopefully across the country. And last slide. And then we will publish a final change package, which will be the best practices recommendation from all of our collective wisdom about how to make this tangible and meaningful improvement effective in systems all the way across the world here. And with that, I'll turn it back to you, Mike.
Great. Well, thanks so much. I am actually going to, in turn, turn it over to Dr. Joey Grover. He's an emergency physician and an EMS physician at University of North Carolina. He's the medical director for Orange County EMS and the EMS fellowship director there. He currently is the chair of the NAMSP Quality and Safety Committee and has been a great partner in this work. So, Joey.
Thank you so much, Michael. So as you all know, you've already heard from some of the top people in the field regarding this topic. They represent the organizing committee. So we've been meeting actually for a few months going through this topic, trying to develop a plan forward for this National Performance Improvement Project. The next step of this entire initiative revolves around you all, the stakeholders. And so what we are trying to do today is to build an advisory committee made up by you all. And so that's really the purpose of this talk, is to try to generate enthusiasm for this topic, and once again, recruit people for what we're describing as our advisory committee. And Tree, you can go to the next slide. So what do we mean by an advisory committee? So first, what we're asking is that you provide a main contact. That will be our main interface between the leads of this project and you all. As an organization, we're excited about including you all in providing feedback of each of the different stages as we progress in this project. We're looking for feedback on the project plan, the project materials. Similarly, we will have no success in recruitment of different agencies if we don't have you all to help in that recruitment process. And so part of the process for you all will be to be serving as an avenue to distribute the resources and materials that we create in order to generate the interest of the local agencies to participate. So part of your role will be sharing and distributing all the communications that we're going to have as this project moves forward. And so once again, the main ask we have is to be able to provide feedback along the way and really serve as that main person of communication for your organization with the larger organizing committee.
Great, Joey. Thanks for going through that. I was going to write in the comments about share any comments that you've got, but I think that Sheree, if you go to the next slide, I think that we want to share a bit of the timeline, and then we want to just kind of talk about a little bit about next steps and get your input, and we have some time for questions and discussion. But really, what we're looking to do is from now until September, develop really the specific package, continue the project plan, pursue some funding to support the activities of the project, and then in the fall, we're going to think about the recruitment of participants, refining the project plans, and continuing to pursue funding. And then we would be ready to implement this project starting in 2022. So we have an organized way of approach, but I think in order to make this the most effective project, we really need your voices to help give shape to what we're thinking through. And again, there's a lot of expertise on this call that is not the organizing committee. So we need your voices. We need to understand all of the details. There's a lot of subtleties in everyday practice that will drive change. And so, I think, Sheree, if you go to the next step, the next slide, that we want to encourage you to kind of give some comments, your thoughts now, and then really sign up for the work of the advisory committee. So thank you all for being here today, and I'm really looking forward to hearing what any initial thoughts or any questions that you've got. So again, thanks to the panel, thanks to Sheree Murphy, and I'm looking forward to continuing this work.
Did have one good suggestion from Mick Gunderson in the chat about using the medical intervention paradigm to kind of highlight, what are the kinds of calls where choosing not to go light and siren might have higher risk, and really understand risk benefit in those scenarios and thinking through that. Thanks for that, Mick.
And Mike, maybe you can answer this question, but Mick has another thought about, do we plan on funding this through participation fees?
that's a great question. That is a common way of funding breakthrough collaboratives at the kind of the hospital and healthcare level. That was not our plan. We are actively seeking other sources of funding to be able to do this, so that organizations that participate don't have to go through the process of coughing up dollars to do it, just primarily because that's hard for organizations to do, and that would really delay the process of getting things started. So we're looking for other sources of funding, and if any of you listening to this know of grant sources or other things that might be able to help fund some software and some staff time around this, that we would love to hear your suggestions around that.
Let me just add on to that. I appreciate that question, Mick. It's not a pay-to-play kind of scenario that we're talking about, but it is fair to say that what we are interested in is some time. We do want people to commit to participate, as we've talked about. So maybe we should have a little bit of discussion about that. How many meetings are we thinking about? How much time? If I'm an agency out there, I'm always thinking like trying to be a pragmatic operations guy, which is the from the cloth I'm cut. So if I'm an EMS chief out there, I need to know how many meetings they're going to be attending, how much time, what level of person within my organization is the right person. And I think there's a lot of answers to that, but maybe we could just chat about that for a quick moment.
That's a great point, Brian. And so the design of the Breakthrough Series is to have the actual time and commitment ask on the part of the participating organizations really be maximized, so that you get the biggest bang for the amount of time that you invest. So you'd want people who are in positions to make decisions and take action in your organization. So fairly high level folks involved in organizations to participate. There will be the 3 official learning sessions that will be the main meetings. There's always the potential for one-on-one coaching and questioning and answering sessions that will happen in between the learning sessions, and then contributing your data and your learning and your comments to the online source where we will that we'll use for collaboration. Probably there's an off-the-shelf product we'll probably use for that. Does that address your questions and concerns pretty well, or?
I think that's great to lay that out. And I would just add that from we are looking for senior leader type folks, but both clinical, operational, from the comm center, I think there's an interest in having a pretty wide scope of representation.
Yeah. That's a great discussion. The other thing that Brooke Burton just brought up, we are lucky to have a partnership with NEMSIS in this work. We've been able to talk about this project with our EPCR vendors and partners in the kind of the clinical documentation space. And we recognize that there's always challenges with the way we collect data. And some of these topics have already come up in our kind of preliminary discussions. So part of any good improvement project is really recognizing where the data is. And we can, when we start an improvement project, it's never that the data is perfect. So we need to tackle, I think we need, as one of our first improvement efforts, we need to tackle kind of data accuracy a little bit, but we can't stop with actually making a difference in the clinical work around building our system. So though we hope to, as part of this, really address some of the data issues that we know about, but again, I think that this work of really thinking through a broad picture of our clinical systems, that we need to do both.
Michael, this is Doug. The one thing I would pipe in about that is that having been on like some of the Compass groups and that sort of thing, I think that sure, it's not perfect, but it is somewhat easier and harder and cleaner to track the lights and sirens information through some of the existing things than it is for some of the others. So for example, the idea of, we had a long discussion over, how do you ensure that everybody in status epilepticus got a seizure medicine? Well, lots of people are coded as having seizure, but most of the seizures have finished before EMS gets there. So if that's the chief complaint, how do you know which ones were actually seizing, and how do you know which ones were seizing for 5 minutes, which is the generally accepted standard, before they even get treated with the anti-epileptic? So you can't really just do a data look and say, okay, this percentage got a benzo that were listed as seizures, because there's a wide gap there. But with this, it's pretty tight. There are some issues, but compared to all of the Compass data points and the NEMSCO data points for QI, this one's pretty tight. So it's a really great place to start.
I couldn't agree more. I couldn't agree more. So I think we're moving forward, and there's a lot of efforts that are going on. Again, like we've seen over the last couple of months, really a focus on the lights and sirens challenges, and I think we want to capture that momentum, really articulate a very specific plan to improve it, and make some effort to change the way that we do business here. And there's a lot of opportunity and a lot of lives to save. So we welcome you to join us. This is an easy way to do it. We're going to put it in the chat, so you can just click on it now and take care of signing up. So please go ahead and do that. We'd love to have your voice in shaping this project and making it successful. I think we're just all very excited to get started, to really put some practical implementation behind something that we know is a real problem in our community. So thanks again for your time, everyone, and we look forward to working together.
Thanks, everybody.
Thank you all.